On behalf of the Western Regional Health Authority Mental Health Unit, in collaboration with the Department of Sociology, Psychology, and Social Work at the Western Campus of the University of the West Indies, through the patronage of our partners, CariMed, Pfizer, Janssen, PAHO, and the National Health Fund, a wonderful good evening. Welcome to the second and final evening of our annual mental health conference. This year, our dynamic speakers will be presenting under the broad theme Mental Health and Well-Being for All, with a further sub-theme of It is a Family Affair. This evening's presentations promise to further promote mental health and wellness, to stimulate discourse, and to enlighten our thoughts further. I want to introduce myself. My name is Georgia Rose, and I will be having the enviable position of introducing our dynamic speakers. First up with us this evening is a wonderful, dynamic, vigorating, and passionate young woman. She completed her pediatric residency at the University of the West Indies and went on to complete a fellowship in pediatric nephrology at the Hospital for Sick Children in Toronto, Ontario, Canada. She is currently pursuing a Master's of Philosophy in Research Epidemiology. Without further wait, kindly permit me to introduce to you Dr. Nadia McLean, who will be speaking to us about getting rid of those monsters, identifying symptoms of trauma in children and adolescents. Dr. McLean, welcome.
Really, really appreciate it. I'm gonna just my screen and just get into the meat of the matter. Okay. So as Ms. Rose said, the presentation today is titled Getting Rid of Those Monsters, Identifying Symptoms of Trauma in Children and Adolescents. So for today, the summary, or what I would aim to do by the end of this presentation, is to describe the types of childhood trauma and its impact, to summarize the response of children to trauma and do this via life cycle development, so infancy, childhood, and adolescence, and to discuss tools for assessment and intervention. So what is trauma? So it's essentially an emotional response caused by experiencing a single or a series of distressing or adverse events. These events may be physical, may be psychological, emotional, or any combination thereof. So the types of childhood trauma are listed here. Bullying, community violence, including domestic and international terrorism, medical trauma, intimate partner violence, physical abuse, sexual abuse, and sex trafficking, and refugee trauma. I've highlighted those that I think are very important in our setting, and we'll go into them in a little bit more detail in the next few slides. So looking at community violence is defined as exposure to intentional acts of interpersonal violence by somebody who is not related to the victim. Is, for example, residing in a volatile area, exposure to gang warfare. And we know that in our setting and our context, many of our children are exposed to gang warfare and community violence. Looking at what's been going on in the news recently, I also thought it was important to mention terrorism or war. And this involves trauma experience due to witnessing international or civil unrest. So if we look at the situations currently in Palestine, Syria, and Ukraine, those children would be at significant risk of experiencing terrorism-related trauma. In terms of intimate partner violence, it really is domestic violence between past or present consorts or spouses. And this includes, but is not limited to, physical, emotional abuse, as well as financial abuse and sexual coercion. Children are often the silent victims of intimate partner violence, but in adolescence, many adolescent adolescent males and females um, experience some sort of intimate partner violence. This is when they're starting to explore romantic relationships. Sex abuse or sex trafficking is the use of a child for sexual stimulation of the perpetrator or observer. Trafficking involves the movement of children or the exchange of anything of value in exchange for a sex act with a minor. And I'll get into more later down in the presentation vulnerabilities, but we can see where children can be particularly susceptible to sex abuse and sex trafficking, and many young women and men do not even know that they are being sex trafficked during the process. Physical abuse relates to physical harm or injury to a child committed by a caregiver or parent. Generally, these leave injuries, visible injuries. And in my practice, we're taught to look for and identify the signs of physical abuse. It's important to note that physical abuse encompasses both accidental and non-accidental injury to the child. So I'd mentioned in the previous slide inequity, and I want to point your attention to a study that was done in 2011 that noted that inequality in childhood affects early childhood development. So if there's systemic inequity or inequality, this means that something that is built into our society or system. It can manifest as inadequate cognitive stimulation, nutritional deficiencies, parental mental illness, or stressors, institutionalization, including imprisonment or being admitted to a mental health facility. And these children end up at greater risk for exposure to societal violence just because of inequity. Protective factors, notably in this study, were maternal education and breastfeeding. There's also a relationship between childhood trauma and racial disparity. I know in our context in Jamaica, the majority of us are Afro-Caribbean descent. However, in the global north, where there is a greater dichotomy in terms of racial representation, Black youth were more likely to experience adverse life events, more so than their white counterparts. There was greater adversity associated with poorer health outcomes in Black children, and there was less access to protective factors. And we see here that access to protective factors were associated with better outcomes. So what are these protective factors? Providing a stable environment, essentially. So parental stability, which would lead to less parental stress, parent-child communication, participation in extracurricular activities, so development of self outside of your parents but with your peers, school safety, which is important in our context given what has been happening in our schools in recent times, community engagement, and family-centered care and involvement. The question that I asked myself in doing this presentation is whether or not poverty qualified as an adverse childhood event or as childhood trauma. So childhood adverse events were directly linked to poverty and is correlated with negative outcomes in adulthood. And we'll go into a little bit more these negative outcomes in later slides. However, there is a cycle of generational poverty that is set up because acute adverse childhood events in childhood is also linked to poverty in adulthood because of irreparable harm to mental health and later societal integration. So we find that poorer children are at increased risk of experiencing adverse life events, and experiencing repeated trauma puts them at a risk of being poor as adults, setting up the cycle of generational poverty. Liao et al. Was able to delineate the relationship between early childhood adverse events and adult poverty, which was shown to be mediated by depression. So, as I said before, Adverse childhood events perpetuate generational poverty. It is associated independently with a higher risk of depression, lower educational attainment, and substance misuse. And this persisted even after adjustment for family socio-economic factors. So the population attributable factors for adverse educational and health outcomes were noted for both adverse childhood events and socioeconomic deprivation, citing both as independent risk factors and also independent targets for management. So just assessing or addressing, the familial socioeconomic status would not reduce the risk of poor health outcomes and adverse educational outcomes without addressing adverse childhood events in its own context. Resilience is something that we've seen a lot in the literature most recently, and it is related to the ability to overcome stress or adversity or a relative resistance to environmental risk. It is really the capacity of a system to withstand shocks and attempts at destabilization. And it is thought to be protective from the adulthood outcomes of adverse childhood events or childhood trauma. So resilience factors noted here, again, we're seeing cognition, so higher cognitive ability, psychological hardiness, high self-esteem and social skills, having a sense of hope, respect and esteem for others, having a sense of control over one's life, not ascribing blame to self for their traumatic experience, the ability to accept support and assistance in addition to having good support, good peer relationships, and again, we're seeing extracurricular activities. So activities outside of the home that develop one's sense of self. So as I said before, there should be the ability to cope. However, the negative life experiences should occur in such a way to encourage recovery. So we see here where if a child is experiencing long-term trauma or repeated instances of trauma or repeated adverse childhood events, then there is no recovery. There's no room for us to offer support because the child is constantly in a high state of stress. Positive social relationships and a robust support system also promotes resilience, as we see in our list here. So is resilience truly protective? There is a meta-analysis done by Waters in 2021, which showed that there was a significant relationship between adverse childhood events, depression, and resilience. And it suggested that trauma was a significant correlate to depression. Resilience seemed to correlate to both, with a stronger relationship being seen between resilience and depression, possibly as a modulating factor. But they did a subgroup analysis of the Connor-Davidson resilience scale and showed that there was not significant differences between groups that reported low versus high resilience, which was in contravention to other previously published studies. The authors noted one limitation that could have affected this is that there was great heterogeneity within the studies that they looked at, which might have confounded the results, and noted that there was room for more research. So this is a summary essentially of the impact of childhood trauma. As you can see, it's far-reaching and devastating. So there's impacts on cognition, brain development, physical health, emotional well-being, relationships and attachments, mental health and behavioral issues. And I'm not sure if we've been on social media looking in the news, but we've seen in recent times where adolescent children tend to resort to violence in terms of resolving their disputes or disagreements. And a lot of questions have come up in the social sphere as to what could be the precipitating factor. And I put it to you that childhood trauma would have been the precipitating factor. Most of these children have lived a significant portion of their lives in a pandemic where there wasn't surety of health, where there was financial hardship, where they're at risk of physical abuse because sometimes school is protective, and these children were at home for almost 2 years. Generally, when you have repeated trauma, what happens is the brain growth is reduced. There's less efficient processing, there's an impaired stress response, and this environmental stress can actually cause changes in gene expression, so-called epigenetics. We see that there are problems with cognition as well, so there's impaired readiness to learn, difficulty with problem solving, language delays, problems with concentration, and poor academic achievements. And I can tell you that throughout the pandemic, the majority of the patients I saw had some amount of language delay. In terms of physical health, you may have sleeping or eating disorders. You may be susceptible to more infectious agents because of poor immune system functioning. You may be susceptible to cardiovascular disease, and stress, emotional stress and trauma has been shown to reduce one's lifespan. Again, noting what's been going on in our schools, emotionally, these children may have difficulty controlling their emotions, trouble recognizing and characterizing the emotions, limited coping skills, increased sensitivity to stress, shame, guilt, excessive worry, and hopelessness. And a lot of these children may also feel helpless in terms of changing their situation. We've also seen behaviorally where there's poor self-regulation, aggression, poor impulse control, risk-taking, sexually acting out, leading to things like adolescent pregnancy and drug and alcohol misuse. And we spoke about the effect of childhood trauma on depression in terms of potentiating it. And many of these children can develop post-traumatic stress disorder. So the clinical features of childhood trauma differ based on your age or your life cycle stage. But in general, there's an emotional response, so there is a mental response to a disturbing event or situation. That response may be acute, meaning during or directly after the event, or chronic, which is a long-term response, and we may have a complex response. So you may have a response to multiple events that may not seem to be related. In terms of the physical effects, we had mentioned serious bodily harm and or injury. And these are the manifestations based on the age. So we have to look at the child in terms of where they are developmentally. So remember that preschool children may not have the language development to be able to express how they feel. So they may have increased fear of being separated from their caregiver, so they become more clingy. They may have more tantrums. They may have poor appetite and weight loss. This, in my practice as a nephrologist, I've seen a significant rise in bedwetting. And generally, when a child who was previously continent comes with bedwetting, we have to explore a very detailed social history. They may have regression in milestones, they may have nightmares, or they may recreate the trauma through play. And as I said, in addition to regression, they may actually have poor progression in terms of their development. For elementary school children, again, they become anxious and fearful. They may worry about their safety. They may become clingy, as with preschoolers. They may feel guilt or shame. They may repeat the traumatic event over and over again as a way of processing. They may have an exaggerated response to something seemingly innocuous, such as a bump or bruise. This is where we see poor school performance, because these children may have a hard time concentrating because of the complexity of emotions that they're feeling. They may have difficulty sleeping as well, and they may become hyper alert. So for middle-aged and high school children, they have more depressive symptoms. They may be able to discuss the traumatic events in detail. Particularly with adolescents, they may develop eating disorders and self-harming behaviors such as cutting. And this is where we may see drug misuse come into play, or sexual risk taking. So as I said before, too many risks. They also can have sleep disturbances, and they may have avoidance of a situation or a place that reminds them of the event. What is common amongst all three groups is that there may be changes in their behavior. So if a parent is going to come to you and say that my child is just not his or herself, even if the child seems to be interactive and normal to you, it would warrant further investigation. So we should really have a high index of suspicion for childhood trauma, given our context especially. And we should look for both externalizing and internalizing behaviors or disorders. So externalizing behaviors are really those things that you can see. So they include acting out, early sexual activity, violence or aggression, emotional lability, truancy, stealing, and property destruction, for instance. Internalizing behaviors now really include withdrawal from social relationships and depressive symptoms. They may have anxiety. And with internalizing symptoms, they may express their feelings through somatization. So this is when children will present to their physician with unexplained pains, gastrointestinal issues, bedwetting, constipation. So generally when they come to see us as pediatricians, we really delve into the social history. Even if it is not in the first visit, we try to establish some amount of rapport. And as the visits continue, you may see that there's been significant adverse childhood events. So in children, poor school performance is usually the earliest and one of the most consistent symptoms of an internalizing disorder. But remember, with externalizing disorders, parents are going to come to you because this child is acting out, child is aggressive. So they're going to notice it and they're going to present earlier. For internalizing behaviors, parents may not notice, particularly if they are having their own stressors to deal with. They may not notice that this child has withdrawn. They may not notice anxiety. And what they may present with is poor school performance or somatic complaints that have no organic cause. So what I'm going to talk about in the next few slides and to close out the presentation is really the development of trauma-centered care and its influence on policy. So the team should be a multidisciplinary team of teachers, guidance counselors, physicians, psychologists, social workers, and ministry officials or policymakers. The aim for practitioners is to support safe and stable family relationships, teach resilience. They should facilitate early intervention and the recognition of adverse childhood events. So there should be a supportive framework wherein a child who is noted to be having trauma can be referred for intervention. And they should be able to assess disruptions in the family unit. The foundation of risk assessment for trauma and chronic or toxic stress is to reduce the risk of long-term sequelae. Again, I'd mentioned earlier before, but it is very important to establish rapport and build trust with not just children, but with the families. It's important to identify early and to report suspected instances of adverse childhood events so that we can have early intervention. And there should be coordination of care amongst teams. It's been difficult, and I find it difficult because all the services tend to be disjointed, but there should be coordination between guidance counselors, pediatricians or family doctors, psychologists, psychiatrists, and social workers, aiming toward the best outcome for the patient. There should also be cross-sector partnerships. So the American Academy of Pediatrics published their recommendations for the facilitation of cross-sector partnerships. And the aim was to achieve equity across the life force and better address childhood adversity. And it adopts concepts from the life course health development theory, wherein intervention should be developmentally and longitudinally focused. Intervention should be holistic, strengths-based, and family-oriented. And it should also be equitable. So it should be the same across systemic inequities, families, and at the individual level. It's important to apply and aggregate individual level data and then reframe it to apply at the family and community level. So the questions that I'd ask are, what are the needs of the community at large and how can we address them? It should be coordinated and well funded. So in summary, childhood trauma has long-term impact. So it affects your perception of reality. It removes your sense of safety. The brain is actually rewired to be in constant fight or flight, and it increases stress hormones throughout the body. Okay? It also creates relationship issues and behavioral issues. And as I had mentioned before, that the brain is actually rewired and gene expression is changed in response to childhood trauma. Children who have suffered childhood trauma are 2 times more likely to become depressed and 3 times more likely to develop anxiety disorders. And we had gone through the types of or causes of trauma, including child abuse, whether it's physical, emotional, or sexual, witness or victim to violence, war or terrorism, and in our context, community violence, and separation from loved ones. I didn't mention bullying in schools in the initial slide, but it is also important to keep an eye out for. So this ends my presentation. Thank you very much for your attention. This is my contact information should you have any questions after this conference. And these are my references.
Thank you so very much, Dr. Benadia McLean. Wonderful, informative presentation. We want to remind our participants and our viewers to save your questions and your comments for the end of the evening. You can go ahead and write them in the chat, but please be ready to represent them as we will be taking our questions and our answers at the end of all our presenters. We want to take a moment to invite our sponsor and their representative, Tisha Thomas from Pfizer, to share with us. Thomas?
Good evening, everyone. Thank you, team from Western Regional Health Authority, and especially the university for having us to present. My name is Tisha Thomas, and I am from Pfizer Pharmaceuticals. Our distributor is Facey Commodity Limited, and we look forward to always being a part of whatever our psychiatry department is doing. As you know from Pfizer, we have a wide range of products. Today I'm in pink, and yes, it's breast cancer month, so you know we do have oncology products. We do have vaccine. Dr. McLean was speaking about pediatrics, so we do have our Prevnar vaccine as well. And also we have a wide women healthcare as well as a cardiology line. But today I will be focusing on our 2 products that are appropriate to psychiatry. So here we go. Thank you very much. So the 2 products that I'll be highlighting today are Aricept and Pristiq. And most persons would be aware of Pristiq, desvenlafaxine, and Aricept, which is donazepam hydrochloride. Now, Pristiq is a dual action antidepressant, inhibiting both serotonin and norepinephrine. And for our story for Pristiq, we have been speaking about the molecule of the many phases of depression. I know as healthcare providers, we see different type of patients every day. Your diabetic patients don't always present the same way. Your hypertensive patients do not always present the same way. And it's the same way at Pfizer we feel about your depressed patient. The phases of depression changes, and so no one treatment is enough. So what we're recommending is a tailored treatment for your major depressive disorder patients. A treatment that will help in terms of their impaired function, the impact on their social life, if they're having poor drug tolerance, if it affects how they work, different things. Now, the formulation for Pristiq is desvenlafaxine, and it is an extended release tablet that is given once per day. We have 50 milligram tablets available in Jamaica. However, you can go up to 100 milligram, and it shows that it has a linear dosing curve when you extend it to the 100 milligram. So feel free to go. Our indication is for your acute patients, for maintenance, and it's for, as I mentioned before, for your MDD patients, what we regularly call depression. Now, a little bit more about Pristiq. For Pristiq, the mechanism of action is that it is a potent and selective serotonin norepinephrine reuptake inhibitor. The mechanism is thought to be related to the potentiation of serotonin and norepinephrine in the central nervous system through the inhibition of their reuptake. And on the next slide, you will see why this is important to us. For your normal mood, in green, everything is aligned. For the negative effects as it relates to the depressed mood, your guilt, your fear, the hostility, the irritability, the loneliness, those are more associated to your serogenic component. However, when it comes to your lack of appetite, I don't want to go to work, decreased interest in self-awareness, lack of energy, and I don't want anybody to say that I don't want to go to work, I don't want anybody to say, but this sounds like me. What we're simply saying from Pfizer today is that it's not a one-shop-fit-all. Not all our patients will do well on SSRIs, and so therefore our Pristiq is an ideal antidepressant combining the serogenic and the noradrenergic mechanism of action for a more effective treatment for your patients. And that is why we're saying depression is unique and your treatment should be unique, and thus Pristiq. The dosage, as I mentioned, it's 50 milligram once daily with or without food. 50 milligram is the starting and the therapeutic dose. There's no need for titration. However, we have had patients in Jamaica who have been or are on the 100 milligram and are doing very well. It should be taken approximately the same time of day, and that is basically because we're saying we want the patient to be consistent in how they're taking their tablets. And it must not be crushed, divided, or chewed or dissolved. And when you're discontinuing, you will taper. And why tapering is important, as you know, with depression, sometimes the patients, when you're tapering, you can tell whether or not they are to continue therapy or they need to discontinue therapy, and they'll be okay. So we recommend a gradual dose reduction for your patients. In terms of your potential for drug-to-drug interactions, I know that all the healthcare providers that are with us in our conference today know that sometimes their patients are on many medications. I know for one, like for example, my dad, which I'll refer to for this afternoon, is on several medications as he gets older. And you realize over the COVID period, he has not left home, his mood has become melancholy, and we had to bring in, his family physician to speak to him. Now, when you think of your choice of therapy, one of the things that you want to talk about is the potential for drug-to-drug interactions. And the only thing I want you to remember from this slide, because we're independent of the CYPD26 pathway, is to remember that that risk is very low. We're independent of the CYPD26 pathway, which is very common, so there's no interaction, and it's a weak inhibitor of the CP3A4. So we ask you to remember that. When you have a polypharmacy patient, think Pristiq. In terms of the efficacy, the study that we will highlight today for the efficacy of your patients is one that talks about about 70% of our, 72% of our patients with comorbidities, they experience excellent results from our Pristiq. And the highlight that I want to move along with the Pristiq for the next slide is in terms of our efficacy. Right. So in terms of the neuro cognition, this is where I want to highlight. A lot of the times we talk about mood, but for us today, we want to talk more than just mood. It's your it's your how you react, how you interact, your psychosomatic. How do you want to go to work? Do you want to get up and do your occupational health? Everything that would affect your daily living. So when, Dr. Crosman, Miss Rose, whoever you're interacting with, and they recognize that you complain every day, I don't want to go to work, I'm feeling tired every day, you just come from vacation, 3 months leave, and you're frustrated. Studies have shown that when we focus just on the serotonin, we may not be getting the patient to goal, but when we move and give them a combination therapy, they can get much greater results. And so we ask that you pay attention to not only the mood of your patients, but also that activity and occupational. Next 2 slides. So in closing, I just want to remind you of the key points that Pristique, and closing on Pristique, improves the social, work, and cognitive function as the quality of life for your patient in major depressive disorder. It improves the whole thing of fatigue, the lack of energy in over 52% of our patients over an 8-week period. And a concern that many patients do have is weight gain. And let me just highlight, it is weight neutral. So I don't know how the camera is letting me look, but if it was a Pristique patient that was slim, they will stay slim. That's what I'm saying. So it's weight neutral. You don't have to worry about weight gain when your patients are on Pristique. And I am unique. And I want you to tell yourself, I am unique. In case you're depressed, the patient depression is also unique. And therefore, doctors, we ask, and healthcare providers, please treat your patients as unique as their symptoms are. The second and last product that I'd like to talk about is our Aricept. That is the slide that we'll move to. Aricept is donazepam, and as you know, donazepam now is on the VEN list. And so we are looking now for more of our patients to be on donazepam over the period of time. I am very passionate about it now more than ever. My father is 85 years old. And Daddy does not want to go anywhere. And we took him to the doctor. And when we took Daddy to the doctor, you can go to the Aricept slide, he was like, the doctor was talking, and the doctor said, do you recognize that your father is responding slowly? No, I didn't recognize because we're just constantly moving. And he says, his response is very slow. Do you recognize when I ask him certain questions, he's not? No, I Aricept for over 15 years. And he lives in my house, and I didn't recognize what was happening to my dad. And we have to pay attention to a lot of our elderly because they were not engaged as they were used to prior to COVID. And so all the activities of doing the puzzles and the this and the that and reading the newspaper and all of that changed. Now, it is a global burden. We want to ensure that you have an early start, the pressure to preserve their optimal function, and of course, product the information. So Aricept is a specific acetylcholinesterase enzyme that degrades acetylcholine. Aricept is believed to exert its therapeutic effects on patients with AD by increasing the amount of acetylcholine available in the brain. So what we want to do primarily with Aricept is to preserve optimal function. I'm sure you know a lot of elderly. So as we go through the next slide, we will talk more about our Aricept. Now, there are 10 million new cases every year of dementia. Now, we know dementia, and all the experts know that dementia have different variables. And for us, let me just be clear, Aricept is just for age-related dementia. But generally speaking, that there is 10 million new cases every year, and persons are living longer. 50 million patients around the world are suffering from dementia. Alzheimer's disease is the most common form of dementia and may create So 60 to 70% of the cases of the total dementia. So it is the most common as we age, especially when they're not interactive, especially when things are not going as they are supposed to. For the next slide, you will see it is becoming a global burden, and therefore the importance of early treatment is important. So simple. Delay in diagnosis and treatment of Alzheimer's disease may have a negative effect on patients' long-term well-being. Treat early. So when the doctor told me about daddy who is 85-year-old, I said, listen to me, doc. I don't know if I can manage the behavioral problems that I hear when I go to the conference. I don't know if I can manage him not eating and all of these things. And I said, let us start. And daddy now turning on him TV because he wasn't watching his TV. Yes, I know recognize. He wasn't watching his TV, J News at 7 and then CVM at 8. Things were changing. We started him and we started to re-engage him, and some of his functional and behavioral patterns have changed. So it's not just memory, because what is lost, but what we can preserve, let us preserve it. We can move to the next slide, because this was talking about dosing. And I just want to highlight in terms of your function that the persistence of treatment is important. So we don't start and stop. And we want to make sure that we do the brand of donazepam. It is assisted in delayed nursing home placement in patients. Again, I'm speaking with Aricept about my dad. I could not manage my dad in a nursing home and my lifestyle. It's better for me to have a caregiver. And there's something called caregiver distress. So if we can delay it, then we can delay it by over 2 years, well, almost 2 years in terms of the months difference. Now, this is the brand. And that is why I want to highlight Aricept, the brand. As you know, there is a difference between brand and generic, and that's the bioavailability of the active ingredient. And so therefore, we ask that the active ingredient done as a pill Aricept be prescribed, because it don't make sense we give them and they're not getting. For example, if we have a drug that the bioavailability of the drug is already 70%, and then we're giving a generic that is less than the 70%, we're basically almost giving a placebo effect at times. So it's better for us to offer that patient the brand and in brand Aricept. So I am going to close in terms of our products that we offer from Pfizer. Just to remind you, one, the Prestige, which is for your patients with major depressive disorder, and secondly, your patients with age-related dementia, and we would give them our Aricept. Thank you for listening, and thank you for having us. UWI, Western Regional Health Psychiatry Department, we are most grateful for you allowing us to participate.
Thank you so very much for that, Pfizer. Wonderful as usual, Tisha. I learned so much, and I'm quite sure that you have provided our healthcare workers who are present on the platform with us, lots of information that they will be using to better support their patients that might be in need of the products that Pfizer offers to us. Wonderful. The next presentation might leave many of us, especially those of us who are parents, literally opening our eyes. The last 2 years took our children, arguably, into singular spaces with limited options for social and in-person engagement. Virtual classrooms lasted up to an excess of 8 hours for some of our little kiddos. And the new reliance on gadgets for entertainment and interaction put many of our children before a screen. We are so pleased to welcome Dr. Georgette Crossman, who will be speaking to us today on the impact of all this screen time on our visual health. Dr. Georgette Crossman, welcome.
I'm going to go over the pre-pandemic statistics, just a little bit about how the eye works for those amongst us who are not medical, just to enlighten you on that. We'll talk about myopia or short-sightedness, a little bit about how the eye develops, signs of childhood visual problems, the effects of the increased screen time, vision screening, and how we optimize for children's health. Now, quite a few patients before the pandemic could see what you're seeing through the glasses now, which is what happened after the pandemic. They're now blurry at distances. All right, so a survey was done by the Morning Consult, and when parents were asked, what was your child's or your children's lifestyle like, and how many hours they would typically spend using their devices before the pandemic, about 60% of parents said their children were spending 3 hours or less on devices. This is all parents. Amidst the pandemic, about 70% said their children were spending at least 4 hours on the devices. Now, where was all that extra screen time going? A lot would say homework, we're doing homework, but then when you drill down deeper, a lot was going to gaming and social media, all right? So games took the #1 spot of where all this extra time was going. Then there were platforms that the children were all on: YouTube, Netflix, Roblox, Fortnite, Twitter, and the list goes on. And these were the platforms they were using to access video or their entertainment content. Now, this is just a short video from the American Academy of Ophthalmology, of how the eye works. And I'll go ahead and play that for you.
Light rays enter the eye through the cornea, pupil, and lens. These light rays are focused on the retina, the light-sensitive tissue lining the back of the eye. The retina sends signals through the optic nerve to the brain, where these signals become the images we see.
I think that's how the eye works normally. Now, what happens when they're short-sighted?
Myopia, or nearsightedness, is where the distance between the cornea and the retina is too long. Light rays focus in front of the retina instead of on it. With myopia, close objects will look clearer, but distant objects will appear blurred.
So when the child is developing, most school-age children are farsighted. They don't need glasses. And so to see near, they do what we call accommodating, and they use their focusing muscles to see objects close to them. Now, as they grow, their eyes will lengthen and the farsightedness will improve on its own. If the farsightedness is significant, though, some of these children may develop other problems such as strabismus, which we call a squint, or amblyopia or lazy eye. This is incorrect. But nearsightedness is where we have a problem today. A parent or both parents may be nearsighted, and therefore genetics may play a role. But in the teenage years, when the eyes are growing rapidly along with the brain, the short-sightedness may get worse. Now, research has shown that time spent outdoors in the daylight hours will reduce the risk of short-sightedness or myopia. So the natural light is good at reducing the child's risks. So how can we tell when these children are having visual problems? If they're not really interested in activities that require them to read or use their eyes, if they're getting easily distracted when they're reading, they're losing their place when they're reading, these are some signs. If they're tilting or turning their head to look at something that's right there in front of them, then we know there may be a problem. Sometimes it's the teachers who actually will point out that there is a problem by saying, little Johnny or little Jane is complaining when I move him or her to the back of the class, and she'd rather come right up to the board. Or you may actually see the little kids, they're going straight to the television screen, right in front of the television screen to see what's happening, and you're sitting at a good distance and you're seeing clearly. So when they have all the screen time, they may experience eye strain. The eyes may actually get dry because they're not blinking as much as they should. The eyes become irritated, there's excessive tearing, and this may cause the vision to become blurry. When you have excessive strain by using objects too close to you, you may develop headaches or pain around the eyes as well from eye strain. Some of the long-term risks of nearsightedness or myopia include retinal detachment, where the nerve layer at the back of the eye will be peeled off, and this can lead to blindness. Glaucoma is another condition in which the pressure in the eye raises and damages the optic nerve, which is responsible for helping you to see, and that can lead to blindness. Cataracts is a condition in which the lens in the eye becomes cloudy. It's usually clear like a glass of water, but usually with time, it may become cloudy like a glass of milk. Now, if you try seeing through a glass of milk, well, you know how that would look. So your vision would decline. So some of the long-term consequences of myopia or nearsightedness will lead to reduction in vision later in life. Persons who are nearsighted, they will not have any learning disabilities, because once you correct the actual problem, which is a myopia, then they will learn quite well. I've spoken about cataracts that can develop over time. Children can be born with cataracts, or they can develop it after birth. And when they're born with the cataracts or have them at a very young age, it can develop abnormal connections between the brain and the eye, which may become irreversible, and we may not be able to improve on the vision later in life. There's a little fad going around about blue light. I'm seeing a lot of persons saying, oh, I'm spending a lot of time on the computer, but I'm okay because I have my blue light lenses. Blue light devices, however, have not been proven to prevent myopia from developing, and the jury is still out on blue light devices. What we do know about blue light is that it will impede the sleep cycle. And so we really want the children not to be on the computers late at night, or at least for 1 hour before bedtime, because it will affect their sleep cycle. So when do we actually look and screen children? Most children are seen by their pediatricians, who do a great job at screening children who may have problems. And most of these children are picked up between ages 3 or 4, or when they're entering elementary school. However, some children may be noted to be having visual problems before that. And if that's the case, then these children should be screened. But how can you improve your children's eye health in this new era of all these devices? You can use bigger screens and position the children further away. In fact, I think the children should not be using cell phones at all, but to make calls, take and make calls. The monitors of the screen should be placed at least an arm's length from the head. And it's better than a phone or a tablet that's held close to the face. As I said before, it will stimulate the eyes to become short-sighted. Now, their posture, they should not be lying down or reclining when using their devices, because not only will this cause pains in their neck and their back, but it will bring the screens too close to the children's eyes again. We want to encourage the children to take frequent breaks and look out the window for 10 objects and write them down. Look out the window, see what's going on, tell me a story. You can give them tasks. You can send them to different rooms in the house and gather stuff or do stuff just to get a little break, give their eyes a little break. You can say, okay, if you want to play for 20 minutes today, then you may have a treat or you reward them somehow. You can set up an alarm, like the kitchen alarms, that will go off in 20 minutes. And when they know that that alarm goes off, it's time to get up and take a break and move around. Good screen time hygiene may lower the risk of myopia and digital eye strain. The 2020 rule has been formulated to help this, and it goes across the board for adults and children. After 20 minutes on the screen, you want to look away for at least 20 seconds, 20 feet away. So 20, 20, 20, all right? And you can put a little sticky pad on the computer screen that says blink or look up just to remind you. Then the young ones, they have this new thing that they think we adults don't know, only if you're really cool. So let me let everyone get cool right now. You tell them to touch grass. And this just means to go outside and play. So a lot of the children, they're staying indoors for hours on the computers. Their eyes are deteriorating because of this. Their general health is deteriorating because of this. So at least for 1 hour per day, they need to go outside and play and get a break from the digital devices. So in general, you want to blink often to keep the eyes nice and moist. You want to adjust the brightness of the screen to match the level of the light in the room, because increasing the screen contrast may help to reduce the strain on the eye strain. The blue light can make it harder for the children to fall asleep. So you want to turn off these devices at least 1 hour before bedtime. The computers, the devices should not be putting the kids to sleep. You should schedule your regular visit to your ophthalmologist. And if you should see any signs of impairment or suspect any vision problems in your child, you find an ophthalmologist right away. I want to thank you very much. Here are my references. And if you have any questions, I'm here to answer those questions. Thank you so much for having me.
She's finished?
Yes, thank you so much, Ms. Rose.
Thank you so very much, Dr. Crossman. That was quite informative. I think we all learned a lot. I love the fact that you have also provided us with lots of tips on how we can, better help our children as we navigate the use of the devices and their visual health or their ophthalmological health. Thank you so very much. We are moving into our third presenter. Dr. Lewis is an adult cardiologist. She received both her undergraduate and postgraduate degrees from the University of the West Indies. She received her Bachelor of Science degree in Medicine and Surgery and a Doctor of Medicine in Internal Medicine in 2005. She was fortunate to later move to Toronto, where she completed a clinical fellowship in adult cardiology at the University of Toronto. During her tenure at the University of Toronto, Dr. Lewis worked at the Toronto General Hospital, Mount Sinai, Toronto Western. Over the years, Dr. Lewis has immersed herself in studies, trainings, and exposure geared towards promoting heart health in the Jamaican population residing in Western Jamaica. In May 2009, she founded the Heart Smart Center to address the growing demand for heart health care in the private sector. She continues to champion the cause for heart health in the Western region, and most recently held a successful Heart Smart Awareness health promotion at the Heart Smart Center. We're very pleased to have Dr. Lewis with us this afternoon as she speaks to us on how we can keep our heart healthy as we take care of our mental health and wellness. Dr. Lewis? Dr. Lewis is having a little bit of technical difficulty. She's joining us. Welcome, Dr. Lewis. We are ready for you.
Are you able to hear me okay and so on?
Loud and clear and lovely. Yes.
Okay, thank you so much. So I'm going to go ahead and share my screen, okay? Thank you very much for that kind introduction. Are you able to see my screen now?
Yes, we can.
All right, thank you. So thank you so much for inviting me to speak about mental health and the heart. And, you know, it's a very interesting topic, mental health at the heart of it all. And so what I wanted to start with is just some of the things that we would commonly associate with the heart, some of the questions or the burning questions that we may have. For example, you know, there's this common scenario, or, you know, we think that a couple has an argument and somewhere either the male or the female, you know, goes off and clutches the chest and has a heart attack. So that burning question, does stress cause heart attacks and strokes? And am I a hypochondriac? Is it all in my head? You know, sometimes we have symptoms, and I get a lot of that because a lot of anxiety symptoms they precipitate palpitations. So I do get quite a few patients who come to me for palpitations, and so some of the times these patients or persons are labeled as hypochondriacs, and they don't get the proper evaluation before we rule out something structural. And then in people who have had a heart attack, which is a major life event, or a diagnosis of heart failure, how does that precipitate mental conditions? So that's kind of a synopsis of how I will approach this talk about the interplay between mental health and the heart. So we'll be looking at it in 4 major groups. Basically, how mental health or psychosocial factors may contribute to the development of heart disease, particularly coronary artery disease, and also the psychosocial response to a diagnosis of heart disease and what possible interventions we can take. So there is a link between psychologic stress and atherosclerosis. There is a direct development between psychological stress or psychosocial stressors, and damage of the cardiac endothelium or the vascular endothelium. And there's also an indirect effect through the aggravation of traditional risk factors for coronary artery disease development, such as cigarette smoking, high blood pressure, and cholesterol. The studies in humans are fairly limited in scope. There is some link between hyperreactivity and cardiovascular disease, but this has not been convincingly made. There really has been some difficulty in quantifying the degree of atherosclerosis in persons who have no symptoms. However, there is some angiographic data that suggests that persons with type A personality have more extensive atherosclerosis. However, there are confounding issues which limit the interpretation. So in one study which evaluated 630 active duty Army personnel between the age of 38 to 45, they had no known coronary artery disease and underwent computed tomography. So it's just a CAT scan, basically, which gives us an image of the vasculature of the heart. And in this study, it didn't really show any correlation between coronary artery calcification, which is a marker of atherosclerosis of plaque buildup, and current psychiatric disorders such as anxiety, hostility, and stress. There have been some stronger epidemiologic studies which have linked psychosocial factors with hard endpoints such as heart attacks or myocardial infarction and sudden death. And these will include the stressors such as bereavement, loss of job, and depression. There are multiple prospective studies that indicate that adverse psychosocial conditions such as job strain, reward effort imbalance, or bullying are showing a higher risk of the development of cardiovascular disease. In the normative aging study, which followed over 1,000 men, ages over 62, who were free of coronary artery disease, and they completed the Minnesota Multiphasic Personality Inventory. They were followed up for about 7 to 8 years, and those with the highest levels of depression, anger, or social competitiveness or dominance had an increased risk of coronary artery disease, including heart attacks which were not fatal, as well as fatal heart attacks, compared with those with the lowest levels of these traits. So there's also a link, particularly in men, in between the response in anger to cardiovascular disease. So there's a link between anger and premature cardiovascular disease in young men. And this was studied in over 1,000 male medical students, and they reported anger reactions to stress by a questionnaire which was administered in medical school. And they were followed up over a course of 36 years. And those with the highest level of anger compared with those with the lowest level had a significant increased risk of premature cardiovascular disease before the age of 55. In persons with type D or distress personality disorder, there is some negative effect on cardiovascular disease. So there is social inhibition plus negative affectivity such as anxiety and sadness is associated with a poor prognosis in cardiovascular disease. A meta-analysis of 11 prospective studies in patients with cardiovascular disease found that after adjusting for the potential confounding factors, age, cardiac disease severity, the probability of mortality and non-fatal myocardial infarction was more than 2 times higher in patients with type D personality than those with non-type D personality. So in persons who have psychosocial stressors, there is an increased risk of coronary artery disease symptoms. So the symptoms of coronary artery disease would usually be chest pain, or it could be shortness of breath, which may be at rest or with effort. There are some people who actually have these symptoms being precipitated by emotional stress. And the effect of emotional stress is multifold. So, our bodies or our hearts respond to this emotional stress through the secretion of catecholamines, which leads to coronary artery vasoconstriction. So the vessels constrict, the peripheral blood vessels constrict as well. So our arteries that lead to high blood pressure. And there is the heart beats faster. So there is an interplay between supply and demand that leads to coronary artery disease or ischemia. So if there is a blockage, so the coronary artery is blocked by the buildup of plaque, then there's the added emotional stress, which leads to constriction of the blood vessels. So there is less blood flow to the area. In addition, the heart rate increases. When the heart rate increases, the work of the heart increases, the oxygen demand increases, and all of these things lead to the development of symptoms of coronary artery disease. And there are several clinical studies which illustrate the effects of cardiac symptoms on quality of life. And so the frequency of stress in patients who have angina, and also the frequency of angina in patients who have depression has been studied. There was one prospective study which compared psychosocial variables in over 700 patients who had chronic stable angina with 50 healthy subjects. The patients with angina experienced more stressful events, which were more frequently disturbing, and they had more psychosomatic symptoms. They had higher scores for hostility and lower levels of overall well-being. These findings are more common among men, even though they were more common among women, even though women had less type A behavior, but there was no obvious explanation for this. In a review of over 1,000 patients with stable coronary artery disease, where 201 had the symptoms of depressions, those with depressive symptoms were significantly more likely than those without symptoms to report more frequent angina or chest pain due to coronary artery disease, physical activity limitation because of this, as well as diminished quality of life, and overall a fair to poor health. In contrast, the correlation of depression with these symptoms there was no correlation of either ejection fraction or stress echocardiographic evidence of ischemia with reported symptom status. Depression is associated with an increased morbidity and mortality in patients with coronary heart disease. In the cardiovascular health study, which studied 5,201 men and women over 65 years of age, they were followed. And they found that a high level of depression was associated with a significant increase in mortality, 18% versus 8% versus 18% for those with a low level of depression. And this was adjusted for the relative risk. For the prevalence of depression after bypass grafting is about 20 to 40%. And this is something that I do see in practice, adjusting to something like that, a major life event and major surgery going, under bypass. It's a very stressful life event. And some people who have not developed adequate coping strategies and do not have adequate family or social support do report depressive symptoms and poor coping after something like this. In a prospective study of 309 patients who were followed for 1 year after CABG, they found that cardiac events, angina, heart failure, myocardial infarction, cardiac arrest, the need for repeat vascularization, and cardiac mortality were more common in those with a major depressive disorder versus 10% without depression. In a larger prospective analysis of 817 patients who were followed for a longer interval, they demonstrated an effect of depression on survival. There were 122 deaths, or 15%. All-cause mortality rate was higher for the patients who had moderate to severe depression at baseline, and for patients with depression of any degree that persisted for 6 months. So we kind of touched on this before in terms of the pathophysiology. How does mental stress or a mental illness contribute to the development of symptomatic coronary artery disease? There's the interplay between, the constriction of the blood vessels, coronary blood flow, and heart muscle supply and demand for oxygen. After a brief period of mental stress, which is similar to that occurs in everyday life, there can be a very transient endothelial dysfunction. Coronary artery disease develops from an interplay of various factors, high cholesterol, genetics, high blood pressure, diabetes, etc. However, the inciting factor is usually endothelial dysfunction. So at the level of the lining of the blood vessel, this is where the plaque either usually remains stable or ruptures. And it's when the plaque ruptures that usually leads to a heart attack. And so these periods of stress can actually trigger a plaque rupture or a heart attack. And longer periods of stress can lead to dysfunction of the endothelium. And this seems to be prevented or mediated by selective endothelin A receptor antagonists. But in terms of clinical use for preventing heart attacks by putting patients on that has not been proven. Psychological stress, perhaps via the activation of the hypothalamic pituitary axis, also produces endothelial injury in animals, an important first step in the generation of atherosclerosis. There is turbulence at the level of the endothelium, which especially at the branch points, and damage to the endothelium will promote the development of fatty buildup or lipoproteins from the circulation into the artery wall, and the attraction of platelets or clotting agents to that area, as well as the release of growth factors that stimulate atherogenesis. Cortisol may also play a role in vasoconstriction, which is induced by catecholamines. The serotonergic system may also modulate sympathetic activity. One of the ways in which we do treat patients who have coronary artery disease to relieve their symptoms is by modulating the sympathetic activity through the use of beta blockers, slowing the heart rate down, relaxing the blood vessels. Mental stress and increased exposure to epinephrine can also lead to platelet activation and deposition. Psychological stress can modify macrophage activity and the inflammatory response, and this is important for the development of plaque and progression and buildup of plaque inside the coronary arteries. Patients who are hypertensive but do not have high cholesterol also have impaired nitric oxide dependent vasodilation during mental stress. Nitric oxide is a potent vasodilator which relaxes the blood vessel and lowers blood pressure and also improves blood flow to the coronary arteries. In stressful situations, the blood cholesterol level seems to rise, and this increase can range from 8% to as high as 65% in certain situations. This has been cited for accountants preparing tax returns, students taking examinations, and job loss after a significant life event. These data suggest an interaction between diet and stressors. Cholesterol increase may also result from free fatty acid mobilization induced by epinephrine. There is also a correlation between high blood pressure and stressful psychosocial variables, and these would include job loss, demanding occupations. Blood pressure seems to return to normal after the removal of the stressor. A prolonged response to stress in those with genetic predisposition to hypertension is also noted. Persons with a family history of high blood pressure show an exaggerated cardiovascular response to stressors compared to those who have normotensive parents. And this might be mediated by catecholamines. So aside from those direct effects of psychosocial stressors and emotional stress, the link with coronary artery disease, particularly symptomatic coronary artery disease, there's also the indirect effects. So some mental health conditions may lead to the adoption of behaviors that increase cardiovascular risk, such as cigarette smoking, alcohol abuse, and inactive lifestyle, failure to take their prescribed medications. And also people with mental health disorders tend to have fewer coping strategies for stressful situations. Evidence shows that after a mental health disorder, which can be brought on by an acute heart disease event, there's a development of depression and anxiety, post-traumatic stress syndrome, as well as these factors which mediated pain, fear of death or disability, and financial strain. There's also the impact of medications which are used to treat mental health disorders on cardiometabolic risk. Some antipsychotics may be associated with obesity and metabolic syndrome, which include insulin resistance, as well as the development of dyslipidemia or abnormal cholesterol profile, as well as irregular heart rhythm, atrial fibrillation, stroke, and death. Examples would be like olanzapine, which seems to have the maximum potential for causing the metabolic syndrome, compared with haloperidol, which seems to have the least potential for this. Clozapine and risperidone also have potential cause for developing the metabolic syndrome, but at a lower potential than olanzapine. So what can we do? What are some of the interventions that we can take to minimize these risks and interplay? One is, of course, setting up multidisciplinary teams that include both mental health and heart disease professionals. In Jamaica, we do have lots of resource limitations, human resource limitations in terms of psychiatrists, psychologists, etc. And also our culture doesn't really support communication between physicians or the healthcare team. So a patient may see a cardiologist and is also seeing the psychiatrist or psychologist, and there are no letters going back and forth between the two. That's something that I do for every single patient. I always try to find out who else they're seeing and make sure that the doctor who is also co-managing them for their comorbid illnesses, whether it's a mental illness or another systemic illness, especially from another specialized system, that they're fully aware of their heart condition, what treatments they're on. Also, I do a drug inventory or just checking to make sure that I know every single drug that they're taking, looking at the interactions and the potential interplay and how it can affect the patient negatively. So this is something we can really do better at. Also employing clinical decision support or electronic health records to coordinate care among the multidisciplinary team. We also need to learn more about the link between mental health and heart disease, and also talk to patients about the relationship between mental health and heart disease. We have a lot of time constraints, and especially, when I worked at Cornwall in the public clinic, you have a lot of patients in front of you. You're trying to get through them, and the time to go through and do, your screening for depression, which we really should be doing, and screening for anxiety and so on. Those things just do not get done. So those are things that we can definitely do better at to support our patients, and also involving their patients and families. This is something that I find is very useful in managing patients with chronic health diseases who have had major life events such as a heart attack or diagnosis of heart failure. Always encourage them to bring a family member to their consultation and involve their family member in the information that is being shared with the patient. Sometimes the patients themselves forget, and that they're supported in the measures that they should be taking at home to maintain a healthy lifestyle. For patients with severe mental health disorders and a pre-existing heart disease, we should also consider prescribing or switching our medications that may have a lower risk for heart disease, and weigh the pros and cons. And also consider the potential interactions between prescribed medications for the heart and psychotropic medications. And also monitoring the patients closely for the development of heart health outcomes and risk factors, and adjust the doses of their heart medicines if required. For the individuals, they need to recognize the signs and symptoms of mental health disorders and heart disease, and talk with their healthcare professional about the conditions in relation to their mental health disorders. Also knowing their family history and their genetic predisposition, and maintaining a healthy lifestyle. In addition, one of the things I talk to patients about is stress management, breathing techniques, particularly my patients who come and they've been going around to several different doctors with palpitations, and they've been labeled as having anxiety attacks. And we do go through all the steps of just making sure that there is no structural heart disease. Sometimes we do find patients who have actual arrhythmias who have been labeled as just having anxiety attacks, and supporting them with techniques for managing their symptoms and also just managing stress. So this would include muscular relaxation techniques, quiet environments, passive and positive attitude, deep breathing, using a mantra, as well as skills training and behavioral training. And I refer a lot for therapy, for them to sit with somebody and talk in a non-judgmental environment. I do not hesitate to refer to my colleagues for that. Physiologic changes, decrease in oxygen. So these relaxation techniques lead to the decrease in oxygen consumption, reduce heart rate and respiratory rate, as well as muscle relaxation. So overall positive benefits for the patient. For researchers, there are lots of areas of unknown. So we need to address the role of social determinants of health and health disparities in improving the intersection between mental health and heart health outcomes, and also understand the link and impact of mental health on the prevention and treatment of heart disease and its risk factors. We can also learn more about the biological pathways between mental health disorders and the heart, so we can understand the immediate, intermediate, and long-term outcomes of chronic inflammation, cardiac reactivity, heart rate variability, and the development of coronary artery calcification. We also need more information about the impact of emotional well-being on mental health and physical health, and also expand the traditional heart disease risk assessment to include mental health disorders. Currently, the risk assessment is really just blood pressure, cholesterol profile, diabetes, yes or no, do you smoke, yes or no. There is no account for the person's mental state or presence of a pre-existing mental health disorder. And we would also need to develop valid and reliable screening instruments to help identify vulnerable populations. So in summary, there's a complex interplay between psychosocial factors or mental health and heart disease. There's some evidence to support the role of emotional stress in the development of coronary atherosclerosis and symptomatic coronary artery disease. And this is mediated by the body's response to stressful situations. In addition, the diagnosis of a major heart event may precipitate a mental health crisis. Thank you very much for inviting me, and I hope that you found this useful or interesting at least.
Thank you so very much, Dr. Lewis. You did not disappoint. I'm in red, so I hope I'm promoting heart health and wellness. We thoroughly enjoyed that. We want to now invite our second sponsor for the evening, Janssen, who will be represented by Marcia Clark, to share with us some of their offerings. Marcia, are you ready for us?
Hi, good evening.
Good evening.
Are you hearing me okay? Congratulations on a great conference so far. It has been quite a day for me, but I'm here to support. And thank you so much for allowing me, Yui, and the Western Regional Mental Health Team. Am I able to share now? Yes, hold on. Let me just start doing that.
Share. Go ahead.
Okay. Okay, so from Janssen Pharmaceuticals, we have been committed and we have always been a supporter for all our teams, especially during this time, Mental Health Week, where well-being and being mentally healthy is a priority. That's what our focus is. But I'm here from Janssen Pharmaceuticals representing tonight for our patients living with schizophrenia. I learned that today. That term, sorry, Dr. Krosman, private joke. Right, so schizophrenics' lives do matter. And from Janssen Pharmaceuticals, we have presentations. Yes, I'm here to share with you tonight. We have presentations here where a patient could live a normal quality life without being stigmatized, without being easily identified without relapsing all the time, because we offer long-acting injectables. So the impact of relapse, it's quite, we know the vicious circle. Patient is hospitalized, we have brain damage. For each relapse, the longer time to remission, it's increased. The time to remission, is increased. So with long-acting injectables from Janssen Pharmaceuticals, such as Invega Sustenna and to come Invega Trinza, we offer the patient don't have to take a medication every day, right? And there are several properties that help to facilitate adherence to therapy, and we have stable levels being maintained all the time. So yes, there are newer presentations that don't have the side effect profile of some of your other older injectables. So for healthcare professionals, yes, I know you know that the side effect profile of Invega Sustenna is much better. But some of our patients or family members, caregivers who may be on this conference, who are not aware, yes, we have drugs like this in our system here in Jamaica. Invega Sustenna is a second generation antipsychotic, and patients are able to be functional. They're able to go back to work. They're able to go back to school. They're able to be productive. That patient who may be a little violent, probably not because of mental illness, but missing their medication, we can actually intervene and prevent some of these relapses. So non-compliance we've identified as a predictor of relapse. So if you have a drug that offers, that reduces the risk of relapse, then definitely it should be employed when possible. And as it relates to costs, I'm going to go here because some of these and long-acting injectables, no, they're not cheap, right? But what we found is that hospitalizations are related to relapses. So we have these rates going up much higher, and then we have healthcare costs being also increased because of these relapses. So let us reduce our healthcare costs. Let us reduce relapses. Let us introduce when Invega Sustenna and Invega Trinza, which is coming up shortly. We should have that available in our public system. I'm speaking it into being because really, let me just go to the next slide. Invega Trinza, it's the same molecule as Invega Sustenna, and it offers similar efficacy and safety that's already been shown with Invega Sustenna. So it's the same molecule, same paliperidone palmitate, just that your injections are being given only 4 times for the year. Can you imagine that? That is available here in Jamaica. So Invega Sustenna and Invega Trinza, they are part of Janssen's commitment to providing innovative therapies and help maintain the quality of life for your patients. So schizophrenics' lives matter. Let us intervene where we can as health professionals to offer these drugs to them. And let's offer it in a positive mode. Let's not offering injectables as something that like we're punishing the patient because you don't take your tablet, you're going to get an injection. Sometimes our society and our patients they fear injectables. Sometimes because they see the other patient who gets an injectable and they are probably a little stoic in their behavior, they stiff, and they don't want to get an injection because they think that the injection will do that to them. So it's for us to communicate to them that you have newer second generation antipsychotics that won't offer them that side effect profile. So offer them in a positive mode so that they're willing to try. And we have, this was actually a publication which was done, our own Dr. Nelson, which evaluated the impact of a community engagement mental health model. And what it showed is that the the positive impact of the use of second generation antipsychotics, antipsychotics like Invega Sustenna and Invega Trinza. So it offers you a stronger benefit to the institution and to the patient, right? And in the end, we're minimizing hospital bed occupancy. The patient is out in the community with their once monthly injection or their once every 3 months injection, and we're eliminated associated inpatient costs and of course balancing out the cost of medication. So pretty much that's what I wanted to share with you tonight. I mean, the dosage you're familiar with, or you can always reach out to me. But another molecule that I would like to mention that is available here in Jamaica is Spravato, which is esketamine. So I've moved on now from our schizophrenic patients to our patients with major depressive disorder. Patients who have been on their antidepressant for 6 months, max out the dosage, no response. And there is a option for them. A new day starts with Spravato. It's actually a nasal spray, and it's available here in Jamaica under a special permit basis. It's to be registered soon. We're awaiting that. But the use of the drug has started here, and we've seen where it makes a difference for these patients who have been suffering with depression, not getting the results. Sometimes the psychiatrist might be having a challenge. They have to switch and mix and match and try again. And so Spravato is here to help solve that problem when you think there's nowhere else to go. All right, so that's something that we're working on. It's available in the private market as well. You could get some more information from me on that, or us. So the importance of hope, where you're not alone. We're all in this together, the Janssen Neuroscience family. And call on us. We're here to support. And it has been quite a day, but I'm glad I was able to share with you. I was actually in Mobay. I'm actually heading in. Thought I would have been in Kingston already, but I had to stop to do this presentation. But that's how special the team is to me and how much I appreciate their being given some time to share with this conference. Congratulations and thank you for having Janssen.
Thank you so much, Janssen and Marsha, for a lovely and very informative presentation. We really appreciate your presence in spite of everything. So we're moving on really well in the evening, and we're coming to a very exciting topic, which I think is most befitting to even the evening out. So before I tell you what this exciting topic is, I want to tell you a little bit about the presenter. Ms. Uki Atkinson is a research analyst at the National Council on Drug Abuse in Jamaica. She heads the National Drug Observatory, which conducts research and surveillance on the drug situation in Jamaica. These include national surveys and qualitative studies on the secondary school, prison general, and homeless populations, as well as clients in drug treatment centers. Mrs. Atkinson has worked in the field of research for over 20 years on local, regional, and international studies focusing on child health, education, HIV policy development, and more recently, the field of drug misuse. She is a former research fellow at the University of the West Indies and a graduate of the University of Ottawa's International Research Internship for Junior Researchers in Kisumu, Kenya. She is also a former fellow of the Inter-American Drug Abuse Control Commission's Observatory on Drugs at the Organization of American States in Washington. And she really is one of our own. She is no stranger to us. And she promises to titillate and stimulate and maybe agitate a little bit with her presentation entitled Molly, Mushrooms, and Marijuana, the New Bad Friends Forever. Mrs. Atkinson? Atkinson joins us, we have some giveaways courtesy of Pfizer. So I hope you are listening and you're ready to get some goodies, courtesy of the lovely, lovely, lovely Pfizer. So I want to show you what these baskets look like. Sorry. And I just want to remind that if you're related to me, you can't win any of these baskets, all right? There's a delay. Oh. So we have a lovely basket here. And Miss Tisha, do we have a specific question that we'd like to ask? Two questions and two baskets, yes. And please be reminded that if you are identified as the winner, please send us an email at psychiatrycrh@gmail.com to make arrangements to claim your prize. And if you don't claim it, I'll keep it for you. Go ahead.
Thank you, Miss Rose. Okay, so we have two giveaway baskets, which are from Facey Commodity and the Pfizer team. And the first question, I did a presentation on two products. The first question I'd like to ask are, what is the mechanism of action of our Pristiq 50 milligram indicated for depression? So what is the mechanism of action for Pristiq 50 milligram, which is indicated for depression? And the second question, okay, so I did Aricept and Pristiq. Those are the names of the products. No, he needs to tell me how does Pristiq work? There are two things that Pristiq does. It does not just do our SSRIs in terms of the serotonin. There's another component of Pristiq. So Omar, thank you for answering so far. So there's something, I mentioned serotonin and I mentioned another part of the reuptake as for your depressed patients. So if you could tell me one, then I'll be fine. I'll be posing another question too from Facey Commodity. Facey Commodity has been around for a very long time, and we have flagship products such as Benjamin's, which we use for sanitization, and we were part of the sanitization team for the fabulous Wellness Day. If you missed the Wellness Day, put on the department, you missed something. However, vitamin C is very important to the immune health. We have 2 vitamin C at Facey Commodity. Could anyone indicate what are the 2 brands that the Facey Commodity offer? Miss Rose actually was showing one of them, but there are 2 brands from Facey Commodity. Okay, so it's Miss Brenton Barnett. Okay, it's a potentiation for serotonin and norepinephrine. That is correct. So you have one of the baskets. Congratulations. That is correct. Or the antidepressant Pristiq. It's the reuptake of serotonin and norepinephrine. As we say, my depression is unique, my patient is unique, and as Dr. Claudine Lewis indicated, as we have our patients, we have to treat them individually. So does we talk about the Pristiq. And the second question was about our vitamin C from Facey Commodity. We have 2 brands of vitamin C at Facey Commodity. Could you tell us the name of the 2 brands? One is in the basket, so you will be getting a vitamin C brand, among other things that are in the gift basket. So you can say something. And Miss Rose was actually showing. Waiting on the responses. Oh, I was told that this person cannot win. Who is that? Oh. I saw it on another screen, but you're not eligible. But it's correct. If I just see one start coming up, then most persons will start getting it. And vitamin C is very important for immune health. All right, so Redoxon, Omar. Can you just please, Omar, if you get the other one? Redoxon is correct. Vitamin C, the effervescence, that's so true. Miss Rose is saying, you know, give it to Omar. Let's see if anybody would add anything to the Redoxon. So yes, Redoxon is from Facey Commodity. And there's another one that we do have. It looks like Omar will be getting it. So I'm going to count down, and if nobody responds, then it's Omar. Yes, Miss Edwards, it's Redoxon, but we have another one. So Omar is still in the lead. There's another brand of vitamin C from Facey Commodity. You cannot enter. So I'm counting down, and if nobody gets the other one, then it is Omar Miller that will have one. So it's 10, no, 9. But that's actually out of Facey, but not a vitamin C. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So I'm going to give it to Omar. The other brand is the Halabaranch vitamin C that we have from Facey Commodity Limited. So Ms. Rose will remind you of the information, and remember that we have our sanitization done by Benjamin's as well. Thank you for participating.
Thank you so very much, Faiza, through Facey, for those lovely giveaways. And we want to remind our winners, you know, to reach out to us so that you can make arrangements to collect your baskets. And remember, if you don't collect them, I will keep them on your behalf. All right. Wonderful, wonderful. psychiatrycrh@gmail.com. So we will be moving into our final presentation. Mrs. Atkinson.
Yes, good morning, good evening, and guests. Can you hear me clearly?
Hear you loud and clear.
Okay. Just give me 1 second. Let me sort out the sharing of the screen. 1 second. I'm almost there. Please let me know when you can see it.
Yes,
good evening. Are we good to go? Okay.
And
all right.
Good to see you and hear you.
For this opportunity to participate in Western Region's mental health conference. It is a pleasure for the NCDA to be continuously involved as a partner in this initiative. So this evening, it is my task to speak about a very interesting topic, Molly, mushrooms, and synthetic marijuana, the new bad friends forever, not best friends forever, but bad friends forever. And permit me to just very quickly outline, if my slides will move, the content, the presentation content. So we're going to speak a little bit about NCDA and what we do, and about the changing context of drug use internationally and locally. We're going to speak a little bit as well about a rapid situation assessment that was conducted earlier this year, and then the strategic responses in terms of what we're doing about the situation that we have discovered exists. So the NCDA is the demand reduction agency that has been in existence since 1983. Most persons know us as, you know, the agency. Let me just move this because I'm not able to see. Just 1 second. All right, 1 second. Most persons know us as the agency that provides public education on substances. We also conduct research on the prevalence and patterns of substance use. We develop and implement evidence-based prevention and treatment programs. We also, yes, we do in public education, as well as partnership, capacity building, local, regional, and international collaborations to address what we know is the changing drug situation and the current drug situation in our hemisphere. So some of the studies that we have conducted that look at, you know, the prevalence, the patterns of substance use, some of the characteristics that we are aware of, and some other characteristics. Overall, as you can see on my slide, the typical substances that we have contended with here in Jamaica include alcohol, cannabis, and tobacco. In terms of the prevalence, the most widely used substance, licit substance, is alcohol, while the most widely used illicit substance is cannabis. The age of onset of substance use has continued to be approximately 12 to 13 years, which is, you know, an early age of onset, and you really want to be able to delay the onset of use as late as possible to be able to mitigate the potential effects later on in life. What our adolescents have reported typically is that 50% of them have easy access to substances. There's, you know, exposure in the home and community. We have issues to do with enforcement of the laws that are on our books in terms of prohibiting access to adolescents. What we know in terms of problematic use from the 2016 National Drug Prevalence Survey, we found that 16% of our population ages 12 to 65 years have been classified as harmful alcohol users. Now, harmful alcohol use, of course, we saw the most extreme example of this the other day when the young lady drank 24 cups of what was said to be white rum to celebrate her 21st birthday. And of course, that is the most extreme form. She died, and that was a most unfortunate incident. But the fact is that harmful use of alcohol that can have that kind of extreme effect. So binge drinking and so on is something that is quite typical in our context, not only in Jamaica, but also in the wider Caribbean region. Now, there is definitely a changing context that we know exists in terms of the substances that are becoming more popular in our midst. And there is an issue as well regarding the legislative framework to cover these new psychoactive substances that are in our midst. So what are psychoactive substances, or new psychoactive substances, I should say, NPS? These are really unregulated substances that are man-made and unregulated, as I said, intended to produce the same sort of effects as illegal drugs. Now, worldwide, globally, there have been over 1,000 NPS. That it's a rapidly changing context where dealers are finding new and novel ways to be able to produce these substances that have psychoactive effects and also very harmful health effects to human beings. So let me just go a little bit to the whole issue of COVID and the impact of COVID on drug use. And we did a local study here, it was online, among 800 participants over the age of 18. So it was an adult sample. And of course, it's not a national study because it was virtual. It was an online survey. Now, but what the survey showed is that among those who used psychoactive substances within the past year, there was a direct relationship between the COVID-19 conditions and increases in substance use. So as you can see there, 37% reported increased use of cannabis, of alcohol, increased uses of alcohol was reported, as well as tobacco and crack cocaine. The reasons for this increased use included, everything to do with coping and trying to deal with the difficult circumstances that people are contending with. So it included stress, anxiety, isolation, social isolation, family problems, and so on. Now, this is what we're really talking about this evening, though. We're talking about these substances, Molly, synthetic marijuana, and mushrooms. And I just want to be able to give some quick facts about each of these substances before I go into the results of our rapid assessment that we did. So for Molly, one of the major things that we want to highlight about this substance, first of all, it's an MDMA. It's lab made. It's similar to, it has stimulant of effects, right? And so it was initially a party drug, probably still is a party drug mainly. And it has a high potential for abuse. So there are no medical benefits. And one of the things that we want to emphasize is the fact that much of what is seized in other jurisdictions as Molly actually contains other adulterants. That's where they mix it with all kind of other substances that have minimal MDMA in it. So they mix it with bath salts, with cocaine, with regular powder, just all sorts of things. And that can contribute to the adverse effects. So MDMA acts on 3 neurotransmitters, the serotonin, dopamine, norepinephrine. And as you can see on my screen, it has a wide range of effects on the body. It increases heart rate, it can cause nausea and dizziness, teeth clenching, psychosis, panic attacks, seizures, depression, and increased risk of unsafe sex. Now, in terms of synthetic marijuana, what we know is that, as I was saying before, this is an NPS. This is something that is man-made. It's made in a lab. It is made to mimic the effects of THC, which is the active ingredient in cannabis. It is marketed as a safe and legal alternative, but really what it is and what we found is that the effects are unpredictable, and can be more dangerous than the effects of cannabis. So persons who use synthetic marijuana run the risk of experiencing extreme anxiety, confusion, paranoia, hallucinations, all of those things that you see listed on my slide. There can also be toxic reactions, elevated blood pressure, kidney damage, seizures, the whole gamut. In terms of psilocybin mushrooms now, so this is a hallucinogen. Psilocybin mushrooms have actually been here in Jamaica for many, many years, over 100 years. It is not typically known to have a high abuse potential. It is also, as we know, it is used in some settings to treat severe depression through microdosing and other methodologies that are used by health practitioners. Now, this is a controversial substance, and I have to say that the effects are quite subjective and they vary considerably depending on who uses it and the kind of context around which you use it, the kind of mood that people are in, the kind of environment they're in. It can cause severe effects like nausea, vomiting, muscle weakness. It can also cause people to have visual and auditory hallucinations, as well as panic reactions, especially when it's taken in larger doses. Now, we know that in 2020, there was increased focus on psilocybin mushrooms because there has been the proliferation of these wellness retreats that are occurring in different places around the island. And I'll show you a few slides on that in a minute. Now, we move into the evidence that we have based on rapid assessments that were conducted in 2021 and 2022. We, in an effort to understand what youth were going through, we did focus group discussions. So this is entirely qualitative, We did focus group discussions in 2021, and then we went back and did them in 2022. We wanted to know how was COVID impacting our secondary school students in the absence of doing, national surveys, which we are typically doing every 4 to 5 years. We wanted to go out and actually touch base with our students to find out what was happening, what was going on with substance use, were there any changes, how were they coping, and we also conducted these qualitative engagements with guidance counselors. So we spoke to students, we spoke to guidance counselors. We did not ask about personal drug use, even though students shared their personal accounts, their personal experiences with substance use. And we explored a range of issues. Now, in 2021, and I'm going to go through this very quickly, because we know the kind of effects that COVID had on adolescents while they were in lockdown. So yes, there was the issue of the lack of devices and so on, but there are a whole range of other issues, which included mental health effects, the issues that they were exposed to abuse at home, the social isolation, all of those things, the difficulty learning online. So for 18 months, our adolescents went through these issues, largely with limited support services and systems in place to be able to address the realities. Now, when we went out in 2022, May of this year, these were the issues that came up. Some of them repeated, but on a much larger scale in terms of the intensity that was described both by students and guidance counselors. So the mental health issues, anxiety, depression, suicidal ideation, the physical aggression. We're seeing these things in the news even up to this week in terms of the amount of physical aggression that's occurring in school settings. Sexualized behavior and pregnancy and the difficulty with learning and settling in class. Of course, one that we are most interested in, the drug use and increased exposure to substance use, the scamming, the inappropriate social media content, parental situation, as described by guidance counselors, is in a serious quandary because parents are largely struggling with being able to positively influence their children, and some of them just have thrown up their hands and don't know how to manage. I'm not saying that this is the majority. Remember, this was not a prevalent survey, so we're not giving any kind of ranking to the level of importance of each of these issues, but we are saying that these came out as significant issues that both students and guidance counselors flagged. The issue of coping with grief and loss and chaotic home environments was also said to be a factor. Now, this is a mental health conference. So of course, I'm going to put some content in here about what was said about the mental health issues that our students are facing. And you can read quickly. You can read what is on my screen. I'm not going to go through all of it because it's a lot. But what these were mainly, these were the guidance counselor sentiments, as well as students who expressed that, not only are they seeing a lot of panic and anxiety and all of that, but they're seeing an increase in things like self-harming behaviors and children talking about, wanting to kill themselves as an escape and seeing it as a better way rather than handling the things that they were exposed to on a daily basis. There were children, even in the focus group discussions, who expressed suicidal ideation because of the things that they were going through. Now let's just go a little bit to the Mali situation, because Mali is one of the things that came out as a significant issue in the focus group discussions, in the rapid assessment. So our students were able to talk about Mali in a very in-depth way that indicates that this thing has proliferated across the island. So you could almost close your eyes and hear the same thing being regurgitated by students in all 13 parishes that we went into. They were able to talk about how the pills look. They were able to talk about how people use it, the kind of methods that people use, how they crush it in food, they put it in drinks, they put it on their ganja spliffs and smoke it. the way that it impacts people, the actual way that people access it, the cost of the pill. And one of the things that we found that is interesting is that there was a range of prices that were quoted for these pills. So the range of prices typically is 2,500 to 3,000 for a pill. But there were students who spoke of pills that cost much less than that. And what that indicates is that there probably is a wide variety of substances that are being cut with the pill, which also raises other concerns in terms of what it is that people are consuming. And they think it is MDMA, but it may also be, some other substances. They were also able to talk about how, the men and the women take different things and how it makes girls, as you can see here, the girl them get on bad when they take it. It make them want sex and they get freaky. So it's also considered, as one young man put it, Miss, I know Molly to be a sex drug. When you're going to have sex, it is something that a lot of people are taking for that purpose. And then they were able to talk about the scope of what they are seeing in terms of a whole heap of people taking it. People are going to the parties. They know people who are taking it from they were young, people who take multiple pills in parties, a whole range. Now, because this is such a short presentation, I'm not able to go through all of the data that we collected about this issue. But we do have a rapid situation assessment report that is, available upon request that you can read much more into what our adolescents and their guidance counselors said about substance use. So we also know that, in the news and so on, and in the dance hall, not everybody, there have been multiple articles about Molly and the fact that people, and also news items and print and television and so on, talking about this Molly issue. Now, just this week, the Broadcasting Commission, as most of us know, put a ban on music that contains drug use, pro drug using lyrics, violent lyrics, all of those things that may influence behavior negatively. I have to say that, yes, there is uproar and people are upset and so on. But what we found in the rapid situation assessment, the adolescents themselves spoke about the significant influence of the music on the things that they know and the things that they do. So while there is this sentiment that, music don't influence behavior, and that is just, parents need to be more, supervise their children more and no expose their children. The age that we are living in now, where there's access to YouTube and Twitter and TikTok and all of those platforms, which also came out in the rapid situation assessment, a lot of the musical content is saturating those spaces and influencing the children, as you can see here, and as you can see here as well, where they were talking about not only the influence on Molly, but also the influence of music on scamming, the influence of music on badness, and on all of these things that we're seeing escalating in our school settings. One of the things that we also found was students talking about being under the influence of substances while on the school compound. There were students who spoke of seeing other students put alcohol into their cups, and you don't know what is in their water bottle, but really what they're doing is drinking, or they go out around the back of the school. There's just a whole lot of delinquent behaviors, if you will, a lot of things that are influencing behaviors based on psychoactive substance use in the school setting. Now, here are some other influences. So remember, now we are accustomed to parties, like all-inclusive parties, where you pay a fee and you go in and you get alcohol for the night. There are now parties and events where you can pay a fee and you actually get a Molly pill or Molly pills throughout the night. And so there are Molly parties, and this was flagged initially by the St. Catherine South Police Division, and that precipitated NCDA's rapid assessment. And we have been collecting a number of, all these flyers and so on about just the changing context of how we are advertising and promoting events. So events are about Molly, events are about hot drugs. These are current events, by the way. Some of them have not even occurred yet. This one is coming up October 31st. And at some of these events, I'm not saying this one in particular, we don't know because it hasn't occurred yet. But we know that at some of these events, Molly pills are popularly sold during these times. Now, it's not just Molly events. There are psilocybin mushroom events. There are ads on social media platforms about psilocybin mushrooms. So there is a change in our context. It's not just a change in Jamaica's context, it's globally. And it is something that requires strategic actions and interventions and awareness on our part. So if we have our head under the sun, or if we are holier than thou and we don't know the kind of music that is impacting our youngsters or our young adults or even our older folks, then it is to our own detriment. Because when, as mental health practitioners, they come before you and they have these issues and they're dealing with complicated issues, if you don't understand the context, then you're at a disadvantage. Some of the additional information that we've gotten on Molly since doing the rapid assessment, we have had increasing calls about experiences of people being sexually assaulted under the influence of Molly. So people, men put it into young girls' drinks, or young boys put it into girls' drinks. There was an account the other day of a young man whose friends put Molly into his drink, and then they took all kind of pictures. And so just a whole host of things are occurring around Molly. In addition to that, we have been told by the Narcotics Police Division that they've seen a significant increase in seizures in the past few weeks compared to the past couple of years that they've been tracking, ecstasy seizures and Molly seizures. So this is something that is raising concern among not only the public health setting, but also in the public security setting. And the fact also is that our legislative framework as it relates to NPS is quite unclear. We have also collected some samples on Molly. We have collected, I have samples here. 1 second. No, I don't have it here. So we have some samples on Molly to be able to submit those to the forensics department for them to be able to conduct chemical testing to determine, is this pure MDMA or are these pills, cut with all sorts of other things, and what are those other things, so that we can determine what's on the market locally. We also have seen a number of social media content which indicate, things on TikTok and all over regarding Molly use and messaging about Molly and so on that are also influencing our young people. So what are some of the strategies that have been devised? Because we're not only about, we're in a crisis and we don't know what to do and where do we go from here. We have worked through strategies at the level of the Ministry of Health, the Ministry of Education, as well as with some of the departments in law enforcement. So first of all, there's a need to increase awareness and capacity, not only in the health sector, but also in the education sector, to be able to understand this whole issue of drug use, to be able to conduct screening and brief interventions, as well as to be able to refer persons for specialized drug treatment if that is necessary. There's also the need to streamline and scale up school-based drug prevention programs. So yes, we have national programs. Yes, we have been doing this thing for many, many years, but there's a need for us to structure it in a way that it follows through from the early childhood level all the way up through adolescence, so that they're getting consistent drug prevention, not only presentation or messages and so on, but also programs, structured programs that are aligned with the school curriculum. There's also a school policy on drug use, which requires updating. We started this process in 2020, and that process needs to be continued. And it was inclusive of key personnel from the school system, to include guidance counselors, HFLE teachers, deans of discipline, so that they would be able to, give significant input based on the things that they know and see on the school compounds, and how it is that the Ministry of Education needs to put in practical measures to be able to address substance use in schools. Of course, there's the issue of parenting, and I didn't share the parenting data because we don't really have the time, but you cannot be doing any intervention with students or children without tackling the home environment. It doesn't make sense for us to, design all of these wonderful programs in schools and we're doing nothing about the home environment, because that's often the root of the problem. Or at least you can try and address the major issues so that the home environment becomes a protective rather than risk factor. There is the issue to scale up surveillance at the port of entry. So that is to do with law enforcement. There is also the development of the development of a robust public education program, public education campaign that's going to tackle not only new psychoactive substances, but also the range of substances that young people are now popularly using, which also include vaping and edibles. Now, public education is very expensive, and that impacts the sustainability of it. So while NCDA has done, snapshot campaigns in the past couple of years, the fact that we've not been able to sustain and saturate the airwaves with campaigns that are impactful and long-term and all of that has been a weakness and a gap. This campaign that is being planned, the intention is that it will run for at least 2 years, and be more impactful. So I always give the example that anytime somebody says to me, anytime I hear somebody say, so what I must take, right away in my mind, I'm hearing Andrews, of course, or too much party last night. Those are things that, because we heard it every morning or every day on the radio, it's something that's ingrained in us. But as the Commissioner of Police outlined the other day when we were doing this presentation, at that time, our source of media was mainly radio and TV. It's a whole different ballgame now with adolescents, and therefore there is need for us to get into the platforms that they are on. So we can't only rely on radio and television to be able to reach adolescents. Absolutely, that's not where they're at. We need to get into TikTok and Instagram and Twitter and all of those other spaces. Studies, of course, there's the need for us to have more robust data on what is actually occurring in our midst. And we are about to, in fact, just this week, folks from the WHO in Geneva, as well as PAHO in BC, were down here training a group to be able to implement a special global school health survey, which is about to start in the next 2 weeks. This survey is not the typical one that we usually conduct across the island. It will be done in 23 schools in St. Catherine. And it's not just a study, it's actually it's initially a baseline study to be followed by 2 years of an intervention. It's a whole design where we'll have 12 intervention schools, 11 control schools, 2 years of intervention, and then follow-up studies to determine the differences, the outcomes and how impactful the interventions were. There's also the National Drug Prevalence Survey, which is going to be conducted nationally among 12 to 65-year-olds using the same methodology that we used in 2016, so we can, compare the kind of changes that are occurring in our midst. And then, thankfully, after we presented this data to the National Security Council a few weeks ago, it was determined that this is sufficiently serious enough to be able to work towards addressing the legislative framework and ensure that it covers new psychoactive substances in a more robust way. So right now we have the Chemical Precursors Act and we have, the Pharmacy Act and so on that covers some of these substances, but it needs to be way more comprehensive. And Trinidad actually has quite a good model because they developed an early warning system and ensured that they put all of these new chemical, all of these NPS and the different, as they develop, they have ensured that their legislative framework is able to address this so that the public security side of it can also be addressed. And I think with that said, okay, no, there's one more slide. So just to say that the NCDA continues to implement the kinds of programs that we have, which cover a broad range of from prevention to treatment, to include things like, universal prevention programs, selective programs for students who are, or children who are more at risk. There are also indicated programs to try and prevent children from becoming dependent on substances. There are family programs. We have family programs that don't only focus on telling parents how to talk to their children about substances. In fact, that's a small component of it. What you're really trying to do is increase family bonding as a protective factor for drug use. There are community programs. We are part of the National Citizen and Security Program that is focused on certain schools and communities, as well as the Child Diversion Program that is in operation now in all parishes. We also are part of the Drug Treatment Court Program, and we have our own counseling and testing workplace programs. And another thing that we are slowly but surely recognizing is the need for harm reduction services and messages in our context, because the fact is, no matter how much people know about substances and know about the effects, the knowledge does not necessarily change behavior. So you always have a small proportion of the society who, despite knowing the impact or seeing the impact, they continue and they persist to use substances. And so you use an approach with those persons. And of course, internationally, there's a whole thrust of, human rights approaches, agenda-based approaches to substance using, to policy, drug policy, and so on. There is a need for us to be able to understand that they will still continue to use, but you give them the tools to be able to do that in a safe and harmless way. Safe for not only themselves, but also others in the society. And with that said, I want to thank you for your attention and thank you for inviting us to participate in this.
On drug abuse. So aptly represented by Mrs. Uke Atkins, you did not disappoint. Okay, thank you so very much. So we attempted to exorcise the demons and the monsters. We sought to regain sight. We engaged in matters of the heart and ended with an eye-opening look at drugs and their attempt to steal our youth. With all of what has been said, I am confident that there must be many questions. We want to open the floor to our questions from our participants. Feel free to throw any question out. We will try our best to respond to them through our quite able presenters. Yes. So I'm going to start at the bottom. I see Stephanie Troncoso asking, and okay, maybe you can respond to that. She says, can you remind us what are some of the things that an untrained eye may look for in youths that may serve as an indicator that they may be engaging in substance use? Okay.
an adolescent who, you know, was actively involved in certain activities, they were excited about doing certain things, and then all of a sudden their behavior has changed. That's often a red flag. If you see where there are changes in their appearance, you know, of course, the typical red eyes, you can smell substances, you know, you smell alcohol, you see them becoming more reclusive, some of them become more aggressive, some of them have changed their peer group. So you know, they had best friends here, and all of a sudden they start to engage with some questionable characters. Those are some typical signs. Of course, decline in academic performance, you know, stopping, changes in eating patterns, but those things could also be an indication of other issues that they're going through. So what you really want to be able to do is have a conversation with adolescents that is non-threatening. As a parent, you want to be able to have that open line of communication, so your adolescent would feel comfortable enough to come to you and tell you anything. It's not very easy for most parents to be so open, but it is certainly something that we encourage as a best practice. Thank you.
I open up the chat to any other questions for any of our other presenters, and you may also send more questions for Mrs. Atkinson if you so desire. So Omar Miller is asking, what is the referral process for students who are suspected or found to be on drugs, and what are the agencies that we may refer these students to?
Okay, thank you for that question, Omar. The NCDA has a network of substance abuse officers across the island. We have a helpline as well. The referral process is that, you know, if you I don't know if you work in the school system, I suspect you do. You can write a referral form, and well, really what you would need to know is who the officers are in each parish. Let me give you the National Council on Drug Abuse's official straight line, and what could help is you could call that line, or you could actually go on our website. There's information on our social media pages as well. And we have a helpline. So, all right, let me start with the first one. 929, hold on, wait, I'm getting a little confused. 876-564-4357 is our helpline. 929-600-224 is our straight line number. And you can get information in terms of the network of officers that we have. Our social media handles are at Drug Free Jamaica, at Drug Free JA, and our website is www.ncda.org.jm. Thank you.
The 564 number?
876-564-4357.
4357. And this is which hotline?
The NCDA helpline. I'm seeing a question here about a female who smoked 2 pieces of health bar and she was acting strange. We would like to know, what exactly is this health bar? Now, I understand your question, but there is no way for me to be able to tell you what that health bar is, because the fact is that in our setting right now, there are a wide range of unregulated products that people are using that are easily accessible. So I wouldn't be able to tell you what that health bar is. I don't know if it contained cannabis or synthetic cannabis, or if it was something else. I'm not sure. There are a number of products, as I said, and different things come in different names. Some of these cannabis dispensaries have substances there that are also unregulated. So and edibles and all of these things are proliferating in our midst. So I'm sorry, I don't know what that health bar was. I mean, we've received calls about adverse reactions to a wide range of things. The other day we got a call about a lady who used a substance in one of our Western parishes. And she said that her reaction was so terrible. She was very, very sick. And when she sought medical attention, nobody was able to help her because they really didn't understand what it is that she took. And in her account of the situation, there were other people who took the substance and they actually died. Now, we don't know about the truth of this, and I'm not trying to be sensational. That is not our style at all. But I just want to emphasize the fact that there are so many things around us now that people are using for different reasons that we really can't tell unless we actually see the product and test the contents.
Thank you so very much for responding. Okay. Dr. Georgette Crossman, are you still with us?
I am. Hi.
Yes, we have a question here for you. Given the adverse impact of increased screen time usage by our children, how do we engage our partners, such as the Ministry of Education, or schools, or pediatricians, on directing the use of screen time by children? So we are seeing, I'm assuming what this person wants to ask is, how do we get these different partners or stakeholders to understand that the early initiation of screen use might be more harmful than beneficial? How do we start that?
All right, so we first have to have an open discussion, and I think a lot of it starts at home. I should say that a lot of the blame has been placed on schoolwork. But when I asked the patients who come to me, I said, okay, what time, if you were online, what time does school start? And school ends at 3 o'clock, fine. And you're finished at 3. Okay, what time do you go to bed? I'm going to bed at 10. And so from 3 to 10, what are you doing? I'm playing Roblox, I'm on YouTube, I'm on TikTok, I'm on Twitter. So a lot of the time is not actually being spent doing schoolwork. All right. So we have to be careful who we blame, etc. Because yes, it has been useful and helpful during the pandemic. Now the kids are face to face. It's just a matter of educating the parents, educating the kids about good screen hygiene. We have to start with the younger ones and the parents who are using the screens as a babysitting tool, because the kids are very quiet. If you take them in public places, you see the kids are very quiet if they have a screen in their hands. And take that screen away, that child is quite uncontrollable. So we first have to start at home with the parents and have them teach the kids good screen hygiene, have them not have the kids on the screens for hours on end without going outside. Then we have to have some discussions with the schools. How much of the schoolwork actually has to be done on the tablets, on the Chromebooks, etc., on the devices? We still have to do some more research locally, and this is evolving. With the pandemic, this is what we saw with the pandemic. Now the children are back face to face, and they're using devices in a hybrid situation most of the time. So most of them are not using the screens as much. But we have to have a discussion with all the stakeholders to see the best way forward. But good screen hygiene is the place we need to start, and we need to start in the homes. I hope I answered your question. Thank you.
Crossman, and you really hit on an important point, that in many instances, the screen has become a very informal and effective babysitter. And I guess maybe it opens up another question. Is it normal to expect our children to be quiet all the time? And if they're not quiet, does it mean that they're naughty or something is wrong with them? Have we as a society developed, what would we call it now, maladaptive expectations of childhood? Dr. McLean, I'm throwing that question over to you. As a society, have we developed maladaptive expectations of what childhood and child development should look like while we are giving the children the screens as almost as a pacifier? Dr. McLean?
Hi. So I feel very strongly about this because I oftentimes speak to parents about childhood behavior when children come in, and they're complaining that the children are difficult to control and they're bouncing off the walls. And I said to them, it's a normal part of childhood. If your child is not testing boundaries, if your child is not bouncing off the wall with activity, um, then I worry. I actually worry more than if the child is acting like a normal child. Uh, we should also note a lot of parents bring children in for assessment for attention deficit hyperactivity disorder, and that diagnosis cannot be made below age 6 because it is normal for a child of that age below 6 to have a shortened attention span and to be a little bit hyperactive. So I think as practitioners, sometimes gentle reassurance to parents when they come in with children concerned about their behavior is needed. And we also need to remind ourselves of what is normal for a child's developmental age. I tell my parents when I see them all the time, I said, we have to meet this child at their developmental age in terms of our expectation and in terms of our discipline.
Dr. McLean, I couldn't agree with you more. And when we think about it, we probably are pathologizing normal childhood behavior and tipping our children over into actual pathology without realizing it. I don't think we've really looked at any studies, and this evening's forum probably did not bring it up, where we think about even the extended screen time use, whether it be for Roblox or social media engagement like TikTok and Instagram, how those things disturb healthy sleep patterns, and how the disturbance of healthy sleep patterns then predispose our children to many other conditions. And maybe that's why we're seeing the hyperactivity and the difficulty sustaining attention and the boredom with everything. And maybe this leads back into the triggers towards wanting to experiment with drugs, recreational drugs such as Molly. Dr. Lewis, I hope you're still with us. We have a question for you. Given the understanding that there is a correlation between heart health and mental health and wellness, how do we promote mental health and wellness and heart health in a population that may not even have the capacity to take care of their heart health? Strategies that you would suggest? Is there something that as a government, from a policy level, things that we should be doing more of? Dr. Lewis, are you hearing us? All right, while we see. Okay, still not hearing her. All right. While Dr. Lewis is able to join us, someone asked about what are the options for free therapy for individuals who cannot afford therapy. Well, the Ministry of Health and Wellness does provide a range of options for individuals to access mental health support across the island. So we have mental health clinics in most parishes. And in some of these parishes, you might find mental health nurses, you might have psychologists, social workers, psychiatrists, and other medical practitioners who are trained and specialize in mental health support. So if you believe that you would benefit from psychotherapy, do not hesitate to reach out to any of these mental health teams across the island. You can go on the Ministry of Health and Wellness website, and they will provide you with direct links and contact numbers for the mental health groups, and you can reach out to them, and you would be amazed that you would be able to access psychotherapy and psychological support. So I hope that will be helpful for you, Shinoy Dennis. All right. Someone has asked a question, Mrs. Atkinson, if we are aware of the long-term effects of the use of Molly. Are we able to respond to that?
That medical science is still trying to determine that. Certainly mental health conditions, anxiety disorders, depression, and those sorts of things have been found to be associated with long-term use. But as I said, the long-term studies have not yet been, have not yet confirmed whether these things are so.
Crossman, someone would like to know, is the viewing of the television less harmful to your eyes than the viewing of the tablet or cell phone screen?
Okay, thank you. Very good question. So the size and the distance from the eyes matters. So the television is not bad. So what I usually suggest to my patients is whatever they're looking at on the screens. For example, they're looking at YouTube, they may be looking at Thomas the Train. And I said, you can allow them to see that on the television if you have a smart television, or you have apps where you can mirror what is going on the screens of the small phones, that small size device, which is not good for the eyes and it's too close to the eyes. And you can mirror that onto the television screen, which is a larger screen and at a further distance, and it's healthier, it's better for the eyes. So yes, the larger the screen and the further the distance the screen is from you, the better it is. Similarly, when the children are in online school at home, instead of having them look all the time at a small screen, if you can get a cable that can connect from the device to the television and have them look at the screens on the television, that's a lot better than having them look at a device so close to them at all times.
Because we're learning quite a lot. Can it be corrected? The damage that is done to the vision, if we catch it early as parents, are there successful interventions? Can it be reversed?
All right, so remember there are genetic factors to myopia and there are environmental factors. So once we catch these children early, what we try to do is to get their best vision before they're about 13 years old. Because the eyes and the brain, they're growing together. And so what we don't want to happen is if the child is having poor vision in one eye more than the other, what will happen is that the brain will prefer one eye over the other. And if that's not corrected in a timely manner, we can never correct that again. Having said that, if a child is short-sighted and we do certain intervention, we may be able to prevent the progression of the short-sightedness. Some children may get a little better as they grow older, but the severity of the short-sightedness that some of these kids are coming in with, having been on these screens for so long and so many hours in the day, we may not be able to reverse what has happened, but we can at least prevent them from getting worse and slow down the rate of the changes in the eye in the negative direction.
Much for that, Dr. Crossman. Dr. Crossman, one final question. I know we've been picking at your brain, but given our appreciation of the impact of the excessive or the increased use of the screen time, should it therefore mean that one of the thrusts of the Ministry of Education and the Ministry of Health is that we should be taking in optical screenings into our schools? Because could it be that there are many children moving around who are experiencing some degree of degeneration to the eyes, and parents not having this information or the access? Because as a child, I don't remember going to have my eyes checked, and I don't think it is a routine thing in our health culture.
Actually, most schools, when they're preparing their children for back to school, these children would have to do a medical, and this is usually done by the pediatricians, and they do a screen, and that screen will pick up some of these children who are not seeing well. Separate and apart from that, the children who fall through the cracks there, sometimes they are picked up by school eye screening programs, which may be from charitable organizations that go around to these schools every now and again and offer these services. So the ministry should ensure then that health report that has to be received at the beginning of the school, it should be mandatory for all schools. That medical report should be mandatory, and the visual screening component of it should be mandatory as well.
So we may need to be advocating a little bit more for visual screenings, at least once per year for our children. I think, a part of our health dialogue is that we talk about, getting our teeth cleaned, and we do our other health checks, but I don't think we are as aggressive about the eyes, Thank you so very much. The person from Pfizer is still with us. Ms. Thomas, someone is asking whether or not Pfizer, whether or not Pristique is available through NHF, or yes, it is. Yes, it is. Yes. So yes, Ms. Kelly. Is Dr. Lewis available to us? We're still not getting through. Okay. We're sorry about that. We do apologize. We've had a lovely evening. Our presenters have been amazing. A panel of all women. Isn't that fabulous? I just love it. Our participants have been equally spectacular. So we want to thank all our partners, our participants, our presenters, our sponsors for your continued support through the year. Each year, face-to-face and virtual, as advocates for mental health and well-being, we bank on your engagement to help us carry through these gems of knowledge. We know that there is no singular safe method to safeguard our mental health and well-being. This evening, we spoke about our mental health as it relates to our early childhood development, exposure to substance use, our visual health, and our heart health. And we want to remind everyone that good health encompasses mental health, which further encompasses so many other aspects of our health. As we create mentally safe spaces for ourselves, let's bear in mind the theme, mental health and well-being for all. Let's therefore create and curate mental safe spaces for each other. Let us extend grace, practice forgiveness, show consideration, be kind, demonstrate gentility, be calm, practice gratitude, and to show a love for each other. We want to thank everyone who, through their presence and their support, has continued to make our conferences a success each year. We hope you will take the information that was shared this afternoon and you will use it as you make decisions and as you agitate for increased health and wellness for all Jamaicans. Once again, on behalf of the Ministry of Health and Wellness, the Western Regional Health Authority Mental Health Unit, the Department of Sociology, Psychology, and Social Work of the University of the West Indies Western Jamaica campus, we want to extend to you wishes for a wonderful evening, and we look forward to seeing you next year. All the best.